Then who in the organization that you'd want to contact, determine who in the organization is responsible for cost, who's charged with developing community-based resources and relationships, who's responsible for the initiatives that we've been discussing, such as readmission penalties, value-based purchasing, and shared savings or bundling opportunities and initiatives. That individual, there may not be, one name is the same or one title is the same by health plan across the country, while many of the structures and functions and regulatory requirements of health plans by Medicare and Medicaid and by insurance regulation on a state level are the same. Nonetheless, from a business perspective, that could vary from plan to plan. Could be a president, CFO. It could be a vice president, medical affairs, chief medical officer, particularly in an ACO environment. Could be a vice president from a health system perspective, or responsible for post-acute care or seniors service lines. It could be on a health plan perspective, director of finance, director of network development, again on a national basis or region or statewide. And then on a product level or market level, could be the director of that product. Again, could be responsible for the Medicare Advantage health plan for that health plan, or the Medicaid product is, alternatively, or all of government programs as well. Wanted to step back. There was also interest just to provide a couple of ideas how to create a baseline of cost of service, so you at least have some really baseline understanding of where you are within your practice. A couple of ways of determining cost of service, one by relative value unit, and then one just simply dividing expenses by your volume of services. With RVUs, I apologize, a slide may have gotten misarranged here. By RVUs, what you want to do is take your CPT codes, take the information that's available on your Medicare contractor site and also posted to the Academy site each year and in the booklets. Take the work and malpractice or professional liability RVUs, multiply those by the volumes for each of your CPT codes to come up with a total of non-physician, and physician also including all licensed professionals and nurse practitioners and PAs as well. So you'd have a subtotal for practice expense RVUs and professional liability RVUs, and then similarly take the work RVUs, professional work RVUs, multiply those by units of service to come up with the total RVUs for by volume for all your services. Add those two numbers together. Again, you can just use the using the Medicare RVUs, and you'll add those together, and you'll have divide your expenses, total expenses, including compensation for yourself, overhead. Any expense to the practice would be added in, and then divided by those total RVUs to give you a total cost per RVU. And just in this example, let's say it's $85. That way, then, when you're going to a payer, if it's still on a fee-for-service basis, you'd have an understanding to at least know where you are from a cost of service, an expanding service, from an RVU offering and negotiation, or of a multiple of the Medicare fee schedule. Again, another basic approach would, again, take all of your expenses, administrative, clinical, space, equipment, purchase services, and then and your compensation and then other professionals' compensation, and divide those by the volumes of services to come up with just a basic unit of measure or metric of cost per service. So there, when you're again in discussions to with health plans, at least you have some baseline understanding of your cost of doing business. And then the opportunity here is that as some of the of those across the academy are having under development or already have experience, is that the non-covered paid expenses and time for current services may be paid under an agreement, and that is a lot of your care coordination and non-face-to-face time with the patient could be included with your cost of service to provide care for those health plan members. So some of the payment method examples that are emerging and existing in the marketplace, as reported by some Academy members, for Medicare Advantage, a fee for service plus a per member per month care coordination fee. So in addition to the fee for service basis, where that's negotiated as a multiple of the Medicare fee schedule, or on just whatever fee schedule that's negotiated with the health plan, to also receive a per member per month payment for your care coordination services and for achieving results on certain measures. As we mentioned later on, you'd want those measures to be clearly defined so that you'll know when, upon reporting, whether they've been satisfied, etc. And this is moving towards capitation and to shared savings. Medicaid managed care duals. Some examples in the marketplace reported to us are payment rates for visits with wraparound services capitation, so that how that visit is described, then beyond payment directly for that encounter. Again, there is additional payment provided for that unit of service for your wraparound services to take care of that beneficiary. Post-acute models, fee-for-service plus shared savings, the ACOs seem to be in that same realm as well. Transition care management, there are examples of payment rates for 30 days of service or 90 days of service with some amount of time or number of visits during those 30 to 90 days, depending again on the relationship around the country. And that ties back to the interest of hospitals in providing good service and also reducing their exposure to readmissions. Consumer-driven, relatively new and on a fee-for-service basis. Contract provisions that I would encourage definition, of course, scope of service, the payment, the methodology behind that payment, whether codes being paid on a coding and a claims basis, what are the adjudication rules. As mentioned, the measures and metrics that may also go into, whether it's reducing readmission rates, hitting certain, aspects of any quality measures, making sure that those measures and metrics are clearly defined. Opportunity for data validation and reconciliation. What are those opportunities? Then the timing for payment, for service and payment reconciliation for a period of time to revise the scope of services and payment for additional terms, and what are those renewal and notice provisions. Contracts cannot violate public policy. They cannot, of course, violate federal laws and state and local laws, etc. But once those minimums are met, and as long as they're in conformance with public policy, they can, and this is where the opportunity is, in a sense, each contract can be customized and provide more value to both parties. And so that's why you have the opportunity to define these provisions and to establish those relationships with the health plans. And then finally, the redress. What happens when what is supposed to happen does not happen? And understand that it's going to be more likely than not that the wherewithal and the financial capacity of the parties is probably going to be heavier weighted to the health plan or the ACO side. So you want to make sure that it's really easy to understand when something that hasn't occurred that should occur is identifiable, and that third parties that aren't part of the agreement would be able to to discern when one party or the other didn't fulfill one of their obligations. So we've covered why, the change in the market, the vulnerability to your patient population panels and your ability to grow, how the market has changed and become really contractually oriented through health plans with the Medicare and Medicaid programs, steps and what to do now, and who to reach out to and communicate in your community across the health plans, health systems, and ACOs. I want to reference something that hopefully you've already made use of some of these materials and are aware of them. The growing evidence base, we're often asked for that support of discussions with health plans. The growing evidence base of home care medicine and impact of your services, reduced utilization, reduced costs, decrease in admissions, readmissions, ER visits, SNF days, etc., and increase in care coordination, medication reconciliation, patient satisfaction, and patient preferences honored. This information is on the Academy site. It's also on IAHnow.com in the literature that's posted there or referenced there. On the Academy site itself, would recommend the 2014 annual meeting presentations dealing with value of house calls in the marketplace across ACOs and for managed care organizations. This information will be updated and with information from ACOs, Independence at Home program, and a marketplace update will be presented at the annual meeting in May of next year, and hope to see all of you there in National Harbor, Maryland. This is all based on information you know about your patient population, the sickest and the frailest, comprising the top 5% of a patient population, though explaining about half of Medicare medical costs. This is one presentation here. Another just on the pie chart, including that your population is generally on an erratic course, take more medications, and of course have higher utilization, and generally are not engaged or look to a payer for health support or management. So that's why health plans are increasingly interested in managing the care and cost of this population. And this is what the opportunity that your practices present to those health plans. An example from a duals population that was presented at the 2014 annual meeting from the University of Arizona, a health plan established with the University of Arizona, that the costliest 5% explain, again, nearly half of cost, and that 20% of that duals population explains 85% of cost. An example from another managed care organization using house calls approach, you can see the decline. This is within 6 months of implementation of the house calls initiative, the decline in admissions, skilled nursing days, and emergency room visits. We see the same thing again in the marketplace and the literature regarding medical costs at the end of life. The darkest line there being all Medicare patients, the blue one at the top, Medicare high risk, and then the line at the bottom, and least costly, the home care managed. This is also being the experience of ACOs that are also applying house calls approaches to caring for their population, and again, is part of the growing evidence base. Be pleasant, be reasonable, be persistent, be well prepared. You can see a couple of thoughts here that go to other aspects of life as well. And you may experience this in your practices as well, where or relationships where with a vendor or with a clinician or in discussions for acquisition, etc. Parties may be interested in paying for a premium for a while, but like other things in life, and even though your practices are in growth and high demand, people will, over time will find substitutes. So make sure things are reasonable for both parties. Just a quick reference that, again, the Academy, we have resources about the regulations regarding Medicare C, which is the Medicare Advantage, health plans, Medicaid managed care, the waivers and definitions. In your states, those with regulatory jurisdiction over health plans could include the departments of health, departments of insurance, and Medicaid programs. Again, today was to be beginning. There are model laws, model contracts, regulations, etc. We will bring those forth in the time ahead. But again, wanted to make sure we had got things started for our Academy members. So again, with that, would encourage your questions. Again, make reference the resources on the Academy site on ihnow.com, and again, hope to see everybody in May 2015. Risk assessments. So questions have come in regarding risk assessments for Medicare Advantage plans. That is something that we can provide more information about the annual wellness visits and risk assessments, and we can do that as part of a plan of care information or as standalone. So to respond to that question, the answer is yes. Risk-based contracts. Risk-based contracts could include the opportunity to gain additional payment if certain measures are hit, targets for readmissions against existing or historical experience, and this is one reason why you want to take a look at your systems to see if you can demonstrate from a patient population perspective that you've had reduced admissions, taking those patient lists to your health plan or to your health system ACO, etc. Generally, we don't see a lot of transference of financial risk onto practices right now. It's usually an opportunity to share in a provision part of the cost savings that would accrue due to your services. Another question is regarding it could be literature or reduction in SNF days. Again, that slide that I presented was out of presentation. So the specific question was, where do we find the reduction in SNF days? That's on the Academy site, annual meetings 2014, and I believe that is going to be the Ronald Schumacher presentation on house calls and managed care organizations. Okay. If anybody wanted to present additional questions or comments, we have a few minutes to do that now and again today to begin a beginning point. Question came in as to how would an independent practice best approach payers to show value and improve contracts? Does this require joining a PHO or other multi-provider network? I think that, as mentioned, this is the information that you want to take to those parties, including can use a PHO, physician hospital organization, and maybe a modern version being the accountable care organization. Since let me back up. You want to review your own data and patients. You want to be able to identify that over time, as they came into your practice, your services, and hopefully be able to attract it, any times of admissions, emergency, room encounters, et cetera, that they've had, the results of your services, et cetera. So that would be just from a basic perspective. In terms of, that would be valuable for any organization. And realize that the benefits of your services are that your interventions, your touches, if you will, your work with the patients that are the most costly to any of these types of payers is through your services. You're going to want to be rewarded for those services as well if you join an accountable care organization or a provider network as well. So when there's shared savings that are demonstrated at the end of the day or end of the year, you want to make sure that there's an attribution of that reward based on your services. We also have from the 2014 presentations, you'll see it from the ACO presentations at the annual meeting, that house calls have produced important cost savings for ACOs. So you want to, again, look at your data and bring those patient lists to, again, that payer organization, that PHO, that health system, et cetera, and see what the experience is of a similar patient in the community that's not in a house call practice as compared to yours. So that would be one way of looking at what their costs are not having house calls, and then the cost of your patient panel. So again, it depends on your marketplace. And again, I would look at the 2014 presentations. Oh yeah, and just to let you know that your services are important in the marketplace and will provide value. And again, today's presentation and including the assessments were meant to be encouraging and provide information. They weren't meant to be in any way discouraging and suggest that you have to be part of something or lose your independent practice in order to participate in this marketplace. It was really to provide some understanding of how you can remain independent and demonstrate that value and that communication in any of those relationships. There's a question here that I'd want to that has to do with credentialing that I'd want to research in terms of credentialing with a Medicare Advantage plan to establish CAQH profiles for providers to participate and provide service for Medicare Advantage patients. Wouldn't be something that I would have thought required as a point of entry of credentialing with the credentialing committee with a health plan, but again, it may be something to that we need to research here and provide that response. Also, do understand that again the reason what this question though provides is that just like in the commercial marketplace, for the employed population, that NCQA, National Committee for Quality Assurance designation of a health plan was an opportunity for a health plan to differentiate themselves and to promote themselves in the marketplace. Similarly, with the Medicare Advantage plans, having the star ratings with the Medicare program, and also NCQA does assess the Medicaid managed care organizations, that those attributions of, again, access, satisfaction, quality measures, and reporting are all important to the health plans. And, as we know, that those are areas where house calls generally, excel. So those measures, and again, that goes to what's important to a health plan, how are they differentiated and succeed and are paid or rewarded in the marketplace, are important to know. So I'm glad that question came up. And again, we'll provide more information about how those the health plans in those different markets are assessed. Hospital admitting privileges may be required, and for managed care organization requirements. It could be a feature, again, of the NCQA and other accreditation organization requirements of health plans, that patients that are seen are able to be admitted to a hospital. And again, some of our house call practices who may be encountering difficulty in the marketplace, and may be based on that reason. Again, thank you for joining this afternoon. As mentioned, today will be a starting point. The next webinar, we'll conduct one later this year after the final rule for payment next year comes out, and we'll make sure that we cover any updates and opportunities regarding chronic care management, the requirements for that service, the documentation, and the revenue opportunity there. Again, thank you for joining us this afternoon, and have a good afternoon. Thanks.